So good afternoon, and thank you for coming to the session this afternoon that FIGO have put on the Postpartum IUD initiative. I'm here with two of my good colleagues, Winnie Sheena from Kenya and Sabauda from Tanzania. So I will start by giving some introduction to FIGO as an organisation, some overview of the initiative in the context of the global unmet need for contraception, and then I'll hand over to my two colleagues who will talk about the initiative in their respective countries. And hopefully at the end, we'll have some time for some questions and answers. So for those of you who aren't familiar with FIGO, we're the International Federation of Gynaecology and Obstetrics, founded in 1954 out of a growing international movement to align best practice and share knowledge in the field of obstetrics and gynaecology. So currently we have a membership base of national societies in over 132 countries. So all of those dots on the map represent a different national society. So we have quite good geographical spread and also representation from both high-income and low-income countries. Broadly, our mandate is for the improvement of women's health and rights and trying to reduce disparities in access to healthcare for women and newborns, and of course, advancing the practice and science of obstetrics and gynaecology. So for some context to this project, which is Postpartum IUD, we're really trying to help address the unmet need for contraception, which is a huge public health issue. As of 2017, there were 885 million women who wanted to avoid pregnancy, but only 3/4 of them were using a modern contraceptive. And when I talk about unmet need, it's defined as the percentage of women of childbearing age, either married or in a union, who wish to prevent or delay childbearing, but are currently not using any modern contraceptive. In 2004, there are currently 214 million of those women with an unmet need, and they're heavily focused in developing regions. So in terms of proportion, sub-Saharan Africa carries 21% of the unmet need, but in terms of absolute number, 70 million, the highest are in South Asia. So on the map there, those countries in red are those with the highest unmet need. A lot of progress has been made in this area, certainly from the 1970s up until around 2000. So the blue line there shows increasing prevalence of contraceptive use, and mirrored below reduction in the unmet need. But I think you can see from around 2000 that progress really plateaued, and we haven't made a lot of advances more recently. So our initiative particularly looks at postpartum family planning, so the prevention of unintended pregnancy and closely spaced pregnancies through the first 12 months following childbirth. The WHO did a consultation on this, and their recommendation is that people have an interval before attempting their next pregnancy of 24 months. Postpartum family planning is one of several proven high-impact practices. This means it's been identified by a group of technical experts, and it has sufficient evidence behind it to be widely recommended as part of comprehensive family planning services. Despite this, some research in 2015 did secondary analysis of postpartum women from 21 low and middle-income countries, and they found that there was an unmet need for postpartum family planning still of around 61%. So why is it important that people space their pregnancies well? So one of the things we're trying to tackle is maternal mortality. And I think one of the best statistics that we can look at is lifetime risk of maternal death. So it's the probability of a 15-year-old dying from a childbirth or pregnancy-related complication across their life, and it factors both maternal mortality ratios and total fertility rates. And I think, quite shockingly, this shows the difference between high-income country and low-income countries. So the lifetime risk of maternal death in a high-income country is 1 in every 3,300. And when you compare that to low-income countries, where it's 1 in every 41, I think that gives us a lot of impetus to why we're doing this work. We know that as well as mortality, there's increased morbidity associated with closely spaced pregnancies, and those less than 12 months. So one of the ways we want to tackle this is ensuring that contraceptive services are available for as many women as possible. And in 2012, it was estimated that if we had optimal use of contraception, that mortality rate could be reduced by 30%. And more recently, in 2017, that was translated as 76,000 deaths averted per year. So in terms of morbidity as well, the WHO paper said that with pregnancies, birth to pregnancy ratios of 6 months or less was associated with increased risk of premature rupturing of membranes, anemia, puerperal endometritis, and preeclampsia. So as well as trying to avoid deaths, we're also looking at the morbidities that arise from closely spaced pregnancies. And then looking beyond the neonatal period, further into child survival, this research combined demographic health survey data. I think it was across 52 countries, so they had a huge amount of data. And this basically shows that the greater the interval between birth and next pregnancy, the higher the percentages that the preceding child will be alive and well nourished. So going across from the bottom is increasing number of months, and you can see a very clear association with increased survival and good nutrition. So why have we focused particularly on postpartum IUD as opposed to other postpartum family planning methods? So it's a long-acting reversible method, and it's medical eligibility criteria, so it's MET category 1, which means there's fewer contraindications for it, and it's appropriate for more women. Particularly in the contexts where we're working, it doesn't require women to come back once they've had their 6-week check, which is important because a lot of them have to travel long distances to reach facilities. It also doesn't rely on ongoing supply of commodities in the same way as some of the shorter acting methods. And in countries where government supply and stockouts can be quite frequent, this is again a massive bonus. Research in 2018 has also shown it to be a more cost-effective method, both compared with short-acting contraceptives and also other long-acting reversible contraceptives. And really importantly, being able to provide an IUD at the point of delivery capitalizes on the increasing rates of institutional deliveries and births that we have seen across the world, particularly in Southern and Eastern Africa and South Asia, which have been increasing a lot over the last couple of decades. So a bit of background to our initiative. It started as a pilot in Sri Lanka, and that was in 2013. Following that, it was successfully given more funding, and we expanded in 2015 to India, Nepal, and Bangladesh, Kenya, and Tanzania. So we work through our national obstetric and gynaecology societies, and the broad aim is to integrate PPIUD service into routine clinical practice. So across those countries, we work in 48 referral hospitals, those with large maternity units, and in some contexts with their associated peripheral sites. So the main activities of the project have been sensitization, so that's with clinicians, but also service managers, policymakers, about the importance of postpartum family planning and PPIUD. One of the largest components has been training, so training medical professionals, either doctors, nurse midwives, and also counsellors in some contexts. We've been working to build the capacity of the facilities to be able to deliver services, so that could have been with equipment for training, but also processes such as setting up referral systems between counselling and the labour room to ensure that a woman who consents is able to go on to receive the IUD. We've worked in most of our countries on the creation of IECs, so information, education, communication materials, either videos. I think this video is in Kenya, if I'm not mistaken, Winnie, trying to encourage male involvement in the process of family planning counselling. Also, we've produced flip charts for counsellors to use. Importantly, and more recently, we've been working in our countries with training institutions to try and embed PPIUD, both theory and practice, into pre-service curriculum. I've got an example there of the nursing curriculum, which my colleagues will talk to you in more detail later. And finally, we've been working with governments to try and ensure that the national data collection systems, so their health management information systems, collect useful indicators in postpartum family planning so we can monitor how the initiative is working on an ongoing basis. Just very briefly I'm not clinical, so just briefly on the insertion technique that we've taught. So we use Kelly's curved forceps and focus on ensuring that there's a high placement at the uterine fundus. Within the training, we would only consider somebody competent once they'd achieved 3 to 5 Mama-U insertions and 5 successful live insertions. We also taught insertion via caesarean section. So just a few numbers. These are as of June 2019. So we had provided training to 7,737 providers in both counselling and insertion, and then a further 10,641 in just postpartum IUD inclusive family planning counselling. And the breakdown of who we've trained has really varied from country to country depending on the context. So as you'll see there at the bottom, Sri Lanka, all of the deliveries were doctor-led, and so that's where the focus of our training was. Whereas if you compare it to Kenya, doctors are a much smaller part and nurse midwives are the largest proportion. So in terms of our counselling, consent and insertion, over 640,000 women have been counselled, and that equated to about 54% of all the women who delivered in the participating facilities. And of those counselled, 11% chose to and went on to receive an IUD. So we have a journal that's free access, which goes into much more detail on this, but we have analysed follow-up at 6 weeks for about nearly 19,000 of our women, and basically that showed expulsion rates of 2.6% and removal rates of 3.7%, which when you compare to the literature is in line with interval IUD, so no different in the postpartum period we have found. We did find at 6-week follow-up that in about 29% of cases threads weren't visible. The only other thing that really came out of the analysis was that there was reduced expulsion associated with caesarean section insertions, those inserted between 10 minutes and 48 hours, and also insertion that had been completed by a nurse. So our key learnings are that postpartum family planning is a vital bridge in meeting that unmet need for contraception, reducing maternal mortality and adverse outcomes, and improving child survival. We found it to be safe and effective as a method, with low expulsion, infection, and perforation rates when the correct insertion technique is mastered. Task shifting allows for the method to be more widely available to women, and we will focus much more on that in the next 2 presentations. And importantly, being able to provide a one-stop procedure in these contexts where women travel long distances or might not have the financial means to return just for contraception services is particularly important in low middle income countries. Okay.